Okay, hello everyone, and thank you for joining us for this episode of the EHR and COCA report. Our guest today is Twila Brase, President and co-founder of the Citizens Council for Health Freedom, a national nonprofit organization dedicated to protecting healthcare choices for patients and physicians, and to preserving the doctor-patient relationship from unwarranted government and corporate third-party intrusions. In 2009, Modern Healthcare named Twila on their list of the 100 most powerful people in healthcare. With the help of her staff, she has been waging numerous national campaigns on various healthcare issues. Her Health Freedom Minute is heard 5 days a week on 800 radio stations across the country. She has given interviews to a wide range of national media outlets, including the Wall Street Journal, NBC Nightly News, NPR, and the New York Times. And she is here today to tell us about her new book entitled Big Brother in the Exam Room, The Dangerous Truth About Electronic Health Records. Twila, welcome to the show.
Thank you so much for inviting me.
So I have the book here. It's still hot, right off the press. I mean, it came out when exactly?
On the 11th, July 11th.
Okay, just barely a week ago, or a little bit more than a week ago. Twila, this is terrific. We don't need to define what the electronic health record is. I think most of our audience are going to be physicians, healthcare professionals, or people who are very familiar with our field. But I wanted to start, and you may not be aware, but ZDog MD, who's a very popular and public figure, a physician who has a very strong online presence, had a short video about the electronic health record on Facebook just a few days ago, where he essentially he sort of vehemently criticizes. It's a call to arms, essentially, to rebel against the electronic health record. But the points that he make, I will summarize them, is number one is electronic health records are bad because they don't talk to one another. Number two, they contain a bunch of irrelevant information that is not clinical. And number three, it has nothing to do with clinical care, but it's more used for billing, primarily. That's the primary design, billing and compliance. And we just need to appeal to Congress to improve the electronic health record. At least that's my impression of his video. That if we did that, if we had a better EHR, and the EHR, they all talk to one another and so forth, everything would be fine. Is that the case? What's your response to that? And so give us, if that's not the right way to think about the EHR, give us the background and situate us a little bit better on that topic.
Well, he's certainly correct about all his complaints. It's just that he really doesn't tackle sort of the root of the problem and the real reason why the electronic health record was imposed. And I'm not even sure, because I haven't yet seen it, but I'm not even sure if he talks about the fact that it was Congress who imposed it, and it was Congress who said it had to do certain things, and they had to put it into their offices, and they had to put it by the bedside to do what the government wants it to do, not to do what the patient and the doctor wanted to do. So I know that there were doctors who had electronic health records before the government EHR was mandated. However, and it worked. It worked for the doctor, it worked for the patient, did what the doctor wanted to do, and they were pleased. But this is not an electronic health record that is that's meant for the patient or the doctor. It is indeed meant for billing, but it's much more than that. There's a physician called Scott Silverstein, who I quote in the book, who says it's just an enterprise-wide command and control system through which every medical decision has to be run. And so, you're a physician, right? So there are things that never get put on the computer that you might like to do. And then it becomes difficult for the doctor to even do that for the patient because it's not on there. And so the electronic health record was made for many other things that have nothing to do with the care of the patient. It has to do with tracking. It has to do with compliance. It has to do with inputting so-called evidence-based medicine guidelines, which are really directives to do what outsiders want to do for the patient. And that's not the way medicine should be, but that's what the electronic health record is.
So Twila, how does one go about dealing with the large variation that does exist in terms of physicians? Meaning, we all know physicians that as cardiologists, me and Michelle are cardiologists, I'm sure we all know folks who are doing stress tests on 85-year-olds on a yearly basis. We know folks who aren't practicing within some wide accepted norm. So if the government's charge is to protect all the, protect their flock, how does one go about protecting their flock without kind of getting this information from the EHR to kind of then regulate out folks? Because certainly it doesn't seem like we're doing a good job of regulating ourselves.
Well, I just want to say it is not the government's job to protect the flock.
Yeah.
It is the government's job to do national defense and really big things, and they are constrained by the Constitution. Healthcare isn't even in their bailiwick. They shouldn't even be involved. And that's part of the problem that we have now, right? So when you talk about somebody who's over age 65, which you just did, and talking about stress tests for them, well, does the patient even care? Because it's not the patient's money, right? It's the government's money. Does the doctor even care? Because it's not the patient's money, and it's trying to get those dollars. And so we really have to get to the root of the problem, which is that the third-party payers are totally involved in the healthcare system, and that's part of the reason we have the electronic health record now, is because all of those payers wanted to get access to all of that data to control what happens in the exam room. But if you want the government, not you particularly, but just whoever's listening, right? If you want the government to be the one who makes the decisions in the exam room, then you just have to think about some other things that the government's involved in and try and figure out if that's the kind of decision making that you would like, right? The kind of weights in the Postal Service, for instance, right? Or whatever government decides, it has to be that way for everybody. But as a physician, that everybody is not everybody. So we really have to get the money back into the hands of the patients. I would certainly like to move toward lifetime traditional indemnity health insurance policies that really put skin in the game for every patient, so that they won't do a stress test because they'll ask you, what's it cost and do I really need it, right? But also the stress tests that are needed will come down in price because it'll be competitive. So, really what we're just talking about is the fact that we have a problem in this country because of the third-party payment system of healthcare.
Yeah.
So that's what I like about your book, Twila, is that you give a very broad historical outline of how it's not that electronic records came about out of thin air just 10 years ago. There's a long history preceding that. Can you go over that a little bit? And to be clear, it's really bipartisan. So it's not a Republican or a Democrat issue. I mean, it's sort of it's a dominant theme that cuts across party ideologies.
Right. So I believe, so it's kind of funny because I have written the book, and I have told some of my staff I need to reread my own book to make sure I know exactly what I said. But the electronic health records, I believe, really began in the 1960s. And I think I list Massachusetts as having one of the first ones. But then if you go into just more recent history, we just can look at what Hillary was trying to do with her plan. Her plan would have created a national healthcare system, but in that plan was practice protocols that every doctor would have to follow. In that plan was a national medical record system. In that plan was unique identifiers for doctors, patients, and everybody else. So she understood that to create a national healthcare system, you have to create a national medical record system. So once you get hold of the data, you can get hold of the entire system. Now, her plan didn't work, right? But HIPAA got passed in 1996, and that was part of her plan. And that took away the privacy rights of everyone. And it allowed everyone who's out there, the doctors, the health plans, the hospitals, everyone else, to actually put everyone's data into an electronic health record and put it online, put it wherever, so that all these people could access it. So that was the beginning of a national healthcare system. And then after that, then President Obama, 4 weeks after he was inaugurated, clearly had this as part of the Recovery Act. The Recovery Act got passed, and that mandated the electronic health record for all physicians, all exam rooms, all hospitals, on penalty of reduced Medicare payments.
So let's spend a minute, or I mean, a couple of minutes talking about HIPAA, because I think what you said is right on, and it's very important. It's a paradox because HIPAA does nothing. In fact, does the opposite of what it claims to do. Like most large pieces of legislation, you take the title and you reverse what it says. But so HIPAA does not protect privacy at all, and in fact, so can you explain that? Specifically what HIPAA does. And
yes, so HIPAA, so I have an entire section on HIPAA because I really want people to understand how it is not a privacy law. I think it's one of the largest deceptions foisted on the American people because they use the word privacy, HIPAA privacy rule, notice of privacy practices, but it's actually the HIPAA disclosure rule, the notice of disclosure practices. The federal government said in 2010 in a regulation that more than 700,000 covered entities, and for your listeners, right? A covered entity is like the health plan, the hospital, the doctor's office, the laboratory, the radiology facility, all those are covered entities. So more than 700,000 covered entities plus 1.5 million business associates of those covered entities have access without the patient's consent as long as those who hold the data choose to share it. And the patient has nothing to say about that. The patient can ask the doctor if they will not share it, but the hospital doesn't have to agree to that request. And if they do agree, they can at any time decide to change their mind. So the patient has really no control over the sharing of their data. But what the federal government didn't mention in 2010 is that also government agencies have access to it. And I remember several years, maybe probably 10 years ago, actually, the Federal Aviation Administration came out with a notice that they were going to declare themselves that they could have access to medical records for public health purposes under HIPAA, the Federal Aviation Administration, right? And so the rule also has what is used to be called the 12 national priority purposes. So for instance, public health is one of them, law enforcement is another, judicial access and administrative access is another, research is another. There are some limits on research. There are some limits on some of these other things too, but I think a really interesting one that really causes people to kind of stand up or take notice is organ procurement. So when you're dying or when your mother is dying or whatever, the hospital can call the local organ procurement organization without your consent, without the patient's consent, without the family's consent, and the local organ procurement organization can come to the hospital without the patient's knowledge at all and start to see the viability of the organs and ask for consent to take them. So I think that's just one of the ways that shows you how HIPAA doesn't give you any control over your data.
What do you say to people who say, well, okay, fine, but who cares if somebody knows what my dose of blood pressure medication is, or who cares if somebody knows that, I have hip arthritis and that sort of thing. Because I think that's a common sense among a lot of people. Say, well, they're sort of resigned. They say, okay, I don't have any privacy, but so be it. Who cares? What other areas of where do you think it could be a problem that people are unaware of?
So I think there's two things. One actually has to do with the privacy, but one has to do with the control. And so a lot of people should not be thinking of privacy as much for the privacy purposes because they think they've got nothing to worry about. But they should be thinking about the control that they lose when they lose privacy. And that's what most people don't realize. So everybody who can have access to your data under HIPAA can use it for all sorts of things, such as creating an entire profile of who you are, who your family is. Now, there was just a study that got reported that these researchers went into the records and they grabbed the emergency contact information of 2.2 million people. They got authority to do this research study. But then they used the emergency contact information to essentially do genetic research on these 2.2 million and their families. So at the end, they had information on more than 7 million people. And they said it was like doing genetic research without the DNA. And so when you don't have privacy and you can't control your information, then outsiders can profile you, they can profit off of you, they can make assessments about your family, they can come into your life because they know information, and they can try to prod you to do certain things. You can get unexpected phone calls because they think you're a health risk, and so now they want to try and convince you to do X, Y, and Z, and you never asked for them to call you, but they've created a risk profile of you in order to figure out whether you're going to be a problem for them or not. So that's one of the things having to do with control. The other thing having to do with privacy itself is you go into the doctor's office, you say certain things to the doctor, you think that that's the only thing that's in the medical record. But actually, and you're sitting here as two physicians, you probably know this, but certain things end up in the medical record that are the doctor's assessments of you. So, or they are words you never thought, you said them, but you never thought they'd actually end up in the record. So we did receive a phone call here from a patient who is going to move her records from Dr. A to Dr. B, but in the meantime, she thought she'd just look and see what they said. And she discovered that on a particular visit, where she was just having a really bad day, and this is a doctor she'd had for such a long time, 20 years or so, this kind of doctor that she walked in and gave him a hug, right? He had written down in the record everything that she had said, the problems with her husband, with her dog, with the house, everything. And he had given her that day a prescription for depression, which she refused. She's like, I'm not depressed. I just told you I had a bad day, right? And he said, well, don't worry about it. Just take it home. I mean, you don't have to take it, but just take it home, right? So I had to explain to her how one of the quality indicators for doctors that they get paid or scored accordingly is whether they have identified somebody with depression, and that he could increase his score by saying he'd found somebody with depression and had prescribed something. And she, horrified about the whole thing, now sees depression in her record, and now she does not want to transfer her record from Dr. A to Dr. B, and she does not know what to do, and she asks me, how do I get this out of my record?
Good luck.
But Twila, we routinely nowadays in the world of Facebook and whatnot voluntarily give up tons of information. So you give up what you like, where you visit, where you eat, and in return you get these very directed advertising about, perhaps if you've eaten at a Mexican food restaurant 7 times, you get coupons for Mexican food. Obviously, the big data, the population health folks see this and say, aha, maybe this is a way we can also help the individual patient by giving them, information that would make them live longer, would make them be healthier. Is that, given what we're voluntarily giving up to, entities like Facebook, and other than, complaints that come up, from different quarters, it doesn't seem like the individuals themselves are that upset about it. What would you say to that?
So it's very much like the idea of consent. So they make a choice to give this information. It's really well known that Facebook has all this data, and they still, because they get to converse with people, they get to talk to people, they get to learn about the lives of their friends and family. But there are some things that they will never put on. They won't. You won't hear them saying certain things, but they will have to say some of those things when they go to the doctor's office. Now, the real question is whether the doctor's office is a safe sanctuary where the confidentiality is protected, or whether it just becomes part of the grid and they can't, in order to actually get the care that they need, they have to confess something that they wouldn't ever put on Facebook, right? But they have to confess it. And now when they figure out that this is all going on the grid and all these big data people can have access to it, well, then what do they say? Do they just hope that you as a physician can figure this out without them having to say it, right? And then can they get treated properly? Do they have to go to a red door clinic so that they don't have to give their name, right? But they aren't treated now by the physician that they trust. Voluntary is one thing, coercive is another.
Is the solution, Twila, to get rid of EHRs, or how do you? What? I know you've outlined some things in your book, so you can. I thought a good opportunity to tell us about what you think the way forward is.
So I would say that I don't know that there's a chapter, and it says what EHRs could have been, right? because there are EHRs that really have worked well for the doctors who created them themselves. They created them to do what they wanted them to do, right? But the problem with the EHR mandate from the government is all of those things in Chapter 2, all of those things they're required to do, report to the federal government, report to, connect up with a lab, use them meaningfully, all of those things, right? That's not what the EHR that the doctors created for themselves was meant to do. That was meant to take care of the patient and the doctor. Really, the EHR mandate needs to go away, or the doctors need to decide that they can deal with not getting that money. I have had lots of doctors tell me that it is more expensive to keep the EHR than it is to lose the money that they would get from not having it, right? So they have to weigh that, and several doctors have gotten rid of their EHR because it's actually unaffordable for them, and it allows confidentiality. So that's one way to look at it. But I think that the electronic health record, it needs to not be on the grid, for one thing. It maybe connects just to the laboratory for the doctor, or it just connects to the radiology facility, but then it doesn't connect up to the National Health Information Network, which is now called the eHealth Exchange, or it doesn't connect up to the State Health Information Exchange, where all sorts of other individuals can get it, where the record locator service can find every record that is on that network, and then they can pull all that information together on the patient. They can know where that patient has gone, anywhere that they have gone. As a cardiologist, you might like to know everywhere that your patient has gone, but that patient may not want to tell you they've been to a psychologist. They may not want to tell you they've been to an oncologist. There may just be things that they don't want to tell you, and they have a right not to tell you, right? But the big systems that are being created through the electronic health record, the state health information exchanges, the National Health Information Exchange, won't give the patients any way to just have a private life. It'll all be accessible to you. But the other thing is that people don't realize is the electronic health record, often all that data is not stored in your clinic, or it might not even be stored in the hospital. It might be stored in the servers of an electronic health record company. And so all of this data essentially can become theirs. And if you don't pay them what they want, if you want to transfer it from one EHR to the next EHR, they may give you difficulty doing that. And so it's been taken even out of the hands of the doctors in the hospitals when they put it on the electronic health record servers, which are, far from the hospital, far from the clinic. And a lot of patients don't know that. They just think it's sitting there in the office.
I want to talk a little bit about the effect that the EHR has on the doctor's own perception of their own skills. If you're constantly and if you're being observed all the time, if you can't make any decision without having to justify why you're making that decision, and you're being observed, it undermines your trust in your own skills. You start losing confidence in what you can do, what you cannot do. You gave the example of screening for depression. Then the doctor was going to think, well, I hadn't thought about screening for depression. Am I a bad doctor because I didn't screen for this? Am I a bad doctor? And it's very easy. You have these things that come top down from academia and from government bureaucracies telling doctors, really, you're really bad. I mean, this is really quality. And if you don't practice according to X, Y, and Z and all these, gazillion things that come down the pike, you're not such a good doctor. And that's really very harmful to the doctor's self-confidence, and trust. And without the doctor has to start off with having some trust in what they can do in order to be able to help. Right, because every medicine is really based on trust, and if you start undermining that, then everything starts to fall apart, and that's so we see it's manifesting now as this epidemic of physician burnout. You talk a little bit about physician burnout. Can you expand on that?
So it was kind of funny. I am trying to think of exactly which publication had the article. It might have been Medical Economics. I can't remember, but it was about burnout. It never mentioned the electronic health record, but there were 200 comments from physicians. And I include, I don't know, maybe 10 or 12 of them, perhaps. But almost all of them were about the electronic health record. And I think, too, that the study from the Physicians Foundation, so the book contains information from more than 125 studies. I think it's probably more than 135 studies, but I gave up counting. But the Physicians Foundation in September 2016 reported on a survey of more than 17,200 physicians. And 48% of them were thinking of either getting out of medicine or severely reducing their patient load. Now, 10,000 baby boomers are entering Medicare every day. And the idea that half of our physicians are thinking about leaving the practice of medicine should be scary to anybody. And that is part of what this, I mean, there may be other complicating factors, but really, I know that physicians got into it for the most part. They got into it because of their love of the patient. They spent all of those years, you know, trying to just get to the point where they could practice on their own. And now they have all sorts of outsiders telling them how to practice, watching over them, penalizing them. You know, it would make anybody want to quit.
Right. And that's why I don't think so. I don't want to put words in his mouth, but ZDogg MD, if he's aiming for a better electronic health record, you know, mandated by Congress, you know, that's not going to be the solution. I mean, the problem is that this constant surveillance of doctors and patients at every single minute, you know, that's really undermining our confidence, our love of medicine, our ability to do what we think is right. You know, it reminds me, I don't know, are you familiar with the Panopticon? The Panopticon was a mental invention, if you will, of Jeremy Bentham, who was a utilitarian philosopher of the early 1800s. And he thought that, he imagined this device that would surveil, it would be a surveillance device for prison systems in general. You know, it would have all knowledge because then the prison administration could operate much more efficiently. You know, it was, and this is, so the EHR is building the Panopticon for healthcare. You know, this giant electronic surveillance system. And I think in your book you make the point that nobody's really interested in changing that, because if you look at its development over the last 2-3 decades, I mean, it's clear that it's the building block for a national healthcare system. And I think at some point you say that, and that's, politicians need it absolutely, because otherwise they have the Medicare disaster on their hands. And so they really feel that they have to move towards a national healthcare system, because, then they'll be able, perhaps not, but they think that way. They'll be able to deal with the unfunding, clearly the Medicare problem that everybody knows is unsolvable, and it's a matter of just a few years from now that it will blow up.
It's still it's not. I don't think it's completely unreasonable to have a skinny set of regulations that came from a central source, which for instance helped with interoperability. Meaning, the internet had a framework which allowed Safari and allowed Netscape Navigator and allowed Internet Explorer and all these things to communicate through one set of one communication protocol. You have, whether you have when you buy a plug for a electrical outlet, there's a set standard that allows things to be relatively seamless. So
do you think the standards are always imposed by the government?
No, they're not always imposed by the government.
Most of the time, the industry itself will come up with its own standards that these. Right.
Well, the industry in this case has not come up with its own standard, right? Meaning, I'm not sure. I don't know that it's clear. It's not clear to me at all that if the government had not intervened at all with EHR, which I think there's no one who is rational that is seeing things that has any issue with the amount of micromanagement that has been attempted by the government in terms of EHR and how bad that has been. There's no question that's been bad. Would it have necessarily been a bad thing to have some, either if industry had not done it, for some group of regulators to say that this is a standard way that everyone must communicate together, and then kind of let that be as a basic ground rule, I don't know that necessarily would be a bad thing. And of course, moving forward now, I mean, it's incredibly hard to move out of this mess right now. I don't see a good way out of this mess, given that you have these 3-4 massive giants and behemoths who refuse to talk to each other, and you have little EMRs like the one that I have that Epic won't talk to, and Epic doesn't talk to it. I mean, it's such a complete mess that I don't necessarily quite understand how we move forward without some group kind of saying that, look, these are the ground rules, and that's what we should do.
So the funny thing about all of that is that HIPAA was supposed to have the ground rules, right? But
right.
It was supposed to lead to interoperability with universal this and that, and right standards,
right,
all sorts of things, right? But HIPAA, of course, violates the patient-doctor relationship. It violates the confidentiality. It says all these people can have access to this very data. And so that's what the government did. And so when you talk about interoperability, and they want to make it interoperable, so you'll see in my book that they talk about, the holy grail of interoperability.
Right.
And no information blocking, right? But the only thing that's protecting people from HIPAA is the lack of interoperability. Right. And so HIPAA was the problem, a bipartisan bill, right, to take over the health data system, to take over the healthcare system. And so, you have to get back to consent, and you have to get back to individual control, and all of those folks now who have made billions of dollars from the mandate, from HIPAA, from their data, everyone, right? They're not as interested in interoperability as they are in just keeping their piece of the pie.
Right.
Actually, right, and
complete dossiers. So I don't know if you got that far to the future. What did I call it? The future considerations, I think is what I called it. But there's just a great quote in there from Judy Faulkner, who's the owner CEO of Epic, right? And she wants everything. She wants everything. She wants to know how long we sleep, what we eat, everything. So it's really about
Right. And, as far as I'm concerned, we already have, there's a readily available solution to the interoperability problem, which is the phone line. If I want to know something and it's not, I pick up the phone, I call the doctor, and I talk to the doctor, and that's available to everybody. And frankly, to me, of course, the doctors are very busy. That's a problem. They're a little too busy in my mind. They're too busy because they are on this treadmill, and they're less available than they should be. I think it's dangerous for patients to have doctors that are so busy. But otherwise, there's nothing better than a phone call, a person-to-person phone call, to get the information that you need, rather than having to log on your screen and go through 15 different password and authentication protocols before you can get a bunch of garbage, which is what you're getting.
Right. Yeah.
But Anish, I think what you were saying earlier, I think it's correct. When you say the industry did not come up with standards, so hospitals are not talking to one another and so forth. So physicians are responsible. Hospitals are have some responsibility in the mess that we're in. I think that's correct. And we've talked about this before on previous episodes, is because we've accepted this handout and this subsidy. We've accepted to eat at the trough of third-party payment, right? And initially it came without any strings attached, but now it has come with now we're paying the price. But we bear some responsibility for in a way putting ourselves in a conflict of interest with the interests of our patients.
Right.
We start accepting being paid by the government or being paid by the third parties, and therefore, in a sense, I think it's not at all unexpected, and in a sense natural, that the third parties who are financing the whole thing, should have a say or be able to have a look at into what's going on in the exam room.
Right. No. That's why Twila's book is really right on point about the fact about really linking up all these things and not staying superficial to just one aspect of EHR, and understanding that how third party payment really corrupts things. But I think part of the reason this came up, and this is what I think, and again, Twila's alluded to, a path forward, which primarily focuses on, as I understand it, reducing the imprint of third-party payers. But part of the reason I think third-party payers arose, and part of the reason there's this general sense that the public wants for things to be managed somehow, is I think partly also our fault, because we as a physician group have not done a very good job of policing ourselves in any good or real way. Meaning, you're still going to have, and there's no good mechanism among physician groups. You're still going to have folks, even if they're paying cash, they'll be paying a lot less for that stress test when they're 75 or whatever. But there will be cardiologists that will convince them to get a stress test on a yearly basis. I've had cardiologists tell me that patients are, patients are annuities, and very charming, incredibly charismatic, and I am convinced, regardless of what system he is in, whether it be right now the money is coming in from a third-party payer, or even if it comes from the patient's pocket, he's that individual is going to be doing a great job of extracting dollars without actually imparting value. So I wish we could say, and I'm a big fan, I've written about the fact that getting third-party payers out will be a definite step forward. But I think something that goes along with that, or should go along with that, is how how we as a group deal with these outliers, because I think patients are really going to be susceptible to them, and I don't know what to do about that.
So I would say that there is no perfection on earth, right? It is possible that I remember talking to a physician once who it was his job for a year to just spot check records at the hospital, and then have conversations where he thought conversations should be necessary. And that would be a way of self-policing yourself, right? But when you do pay your own dollars, yes. I mean, look at away from, think about all the places where you pay money that is like, okay, I should never purchase that, or I can't believe that deal, right?
Yep.
And so there will always be outliers, and there will always be people who want to take advantage. And it's not just in medicine; it's everywhere, right? And it would be good for physicians to police, but the individuals who have the money in their hand do start being much better policemen on their.
No question.
It is in the game.
Yeah, no question.
Twila, let me ask you something about sort of recent developments in policy and so forth. There was this hope from the government and the big corporate conglomerates that the electronic health record would provide the information that they need, for their own purposes. Do you get a sense that even at that level, it hasn't really fulfilled its promise, even its Machiavellian promise, or utilitarian promise? It's not really doing a very good job, because they've had that information now for the last 5 years or so, or however long it's been. And they're not running ACOs any more efficiently than they were before. They're still losing money. So they have the information. It's not making the system work. Do you think it's going to give them pause as to perhaps reconsider what the value of this whole enterprise was?
I don't think so, because I think a lot of them see a different future, and that future doesn't have as many doctors in it. End of statement. I think that they see physician's assistants and nurse practitioners taking the place of many physicians. I have a story in the book about a medical assistant who at a clinic is now doing the history and physical, right? And the doctor says he doesn't really like it, but at least he's not still there at 8 o'clock while the rest of the staff is at home. And so that's a terrible place where the electronic health record has driven doctors and the patient-doctor relationship, that these folks, and I'm a nurse, right? I'm a nurse, I'm an emergency room nurse. I'm not doing it anymore, but, very fast-paced, a lot of different things you have to try and handle coming through the door. But the idea that somebody who's not a doctor can be the same as a doctor, I think that's really where it's going. I sort of looked at the nurse practitioners, their main organization, right? And they talked about getting a doctor of nursing practice, I think is what they call it. And of course, then they could be called a doctor. And what dreadful confusion for the patients who think they've got a physician when they've got a nurse. And I'm a nurse, and I love doctors and I love nurses, but they're just not the same. The quality of, not the quality, but the time of clinical education, one's medical education, one's nursing education. But I think that they view the computer as a physician will populate the computer with protocols, and then the mid-level staff will implement them. And that's a bad.
Well, give us some hope. Give us some hope, Twila. What? Tell us about the other things that your organization is doing. And go ahead.
Yes, because our whole plan, of course, is we see all of this moving forward. We got the electronic health record mandate. We got the Affordable Care Act, which has made insurance unaffordable. We got Medicare, which is set to go bankrupt in 8 years, right? But from our organization's perspective, all those laws could stay in place and just nobody has to even follow them. And so we're sort of like moving to build a system on the outside. So what we really want is we want younger people to never have to go into Medicare. We want individual policies, perhaps even pre-birth, right? Because that's actuarially, it's easy to figure out how many $1 million babies there's going to be, right? And then the parents pay for this for a child, and then they give it to the child at maturity, and then the child takes it into the world with them. They aren't trapped in their job. They're not trapped with a pre-existing condition because they left their family policy. They're not trapped with the pre-existing condition because they left their employer policy, right? And then they don't have to go into Medicare. And then the insurance companies, and these are indemnity policies, so they're not health plans. In our world, the health plan goes away because the health plan is not an insurance company. It's just a corporate version of socialized medicine. And so that's one reason why we started the wedge, the wedge of health freedom, which is to encourage doctors to come out of third-party payment and for us to help patients find them so that we can build a system that leaves insurance outside, where I'll just tell a story. So this guy who's almost 80 told me that in the early 1970s, he needed heart surgery. And so his traditional indemnity insurance company sent him a check for $68,000. And he used that to pay his cardiologist and to pay his hospital. And he said it was so simple. And see, that's how simple it can be. And that's how all that money of third-party payment can go back into actually, the rest of your life. So the premiums don't have to be that high. The doctor's bills don't have to be that high. Doctors don't have to spend all their time doing things that don't even make a difference in patient care. It's all this non-clinical stuff, right? And so our plan is to build the system outside of today's system. And eventually, if you're not in Medicare, there's so many of those laws, including the electronic health record mandate and all of that kind of stuff, that won't even pertain to you. And so they can sit there as laws, but they're really kind of, in the dust, doing nothing because nobody has to follow them. Because I just don't see Congress getting rid of any of them. I just don't see Congress having enough unity, enough clarity, enough willingness to do something to really help patients and Americans when it comes to their health care. And so the system has to be built by innovative, brave people and doctors who are just tired of being told what to do when they've been so well trained.
So go ahead, Aish.
Twila, thank you thanks for being such a loud and clear voice that's pushing back against much of the nonsensical chaos that you see coming our way. So
yeah, and I will on the show notes, which will be at accountandcoca.com/episode 16, I will have all the links. I really want to encourage everybody to go to your website, to the website of your organization, including this effort that you have called jointhewedge.com. Is that correct?
That's correct.
Jointhewedge.com, which lists all the physicians and the outpatient surgery centers and all the places where you can get great care outside of the system.
Right.
And I consult that website from time to time. I always look to see if Coca Cardiology is on it. So far, unfortunately, Coca Cardiology is not on the map of the Wedge of Freedom. I'm hoping one day that we will have Coca Cardiology join the Wedge. But
we would like this, and we do have. I know we have a radiology facility. I know we have some go to your home doctors, right? They'll go to your home, right? We do not have the Surgery Center of Oklahoma, although I want to take this opportunity to just say their name. And the reason is because they have Medicare doctors that come in and do it, and so they're still tied to Medicare, right? And so they can't. But this is a cash checker charge. A surgery facility whose surgery is so much less. And that's what the wedge is. All of these doctors, which are cash checker charge, where the costs are so much less, that even if you have a high deductible, it makes sense to pay cash. It makes sense because you will have more money at the end of the day in your pocket.
Absolutely. And it's going to make more and more sense as time goes by, because more and more, cost is getting shifted onto the patient. And that's really the way forward. Twila, I want to thank you very, very much for coming on the show. It was really delightful to have you, very instructive, informative. The book, again, is Big Brother in the Exam Room, The Dangerous Truth About the Electronic Health Records, available on Amazon. And I will have all the links on the show notes.
That's wonderful. Thank you so much for interviewing me.
All right.
Of course. Thanks so much, Twila. Take care.
Bye-bye.
Bye-bye.